Hello, my name's Stephen Evans. I'm a Band 6 dietitian working in Cardiff and Vale, currently working in the University Hospital of Wales on critical care. I'm going to talk to you today about our service during COVID-19, some of the challenges we faced, how we increased our service provision and some of the nutritional management of COVID-19 patients. And then my colleague Rebecca is going to talk to you about our service evaluation and some of the outcomes that we had. At the onset of COVID, we were two Band 6 dietitians and a Band 8A clinical lead. It became apparent to us very quickly that we needed to increase our service provision to meet the demands of the COVID-19 patients. We had new patients being admitted every day with a prediction of an exponential increase. So we went about selecting from our pre-existing pool of dietitians those with the relevant experience to upskill to start working on critical care. We did this by doing one-to-one tutorial sessions, but also by doing a group hour-and-a-half long session where we covered some of the fundamentals of nutrition and critical care, as well as the emerging evidence on nutritional management in COVID-19 patients that came from Europe, countries that had already had their first peak, and there was some evidence coming about the nutritional management of these patients. So we were looking at that and considering all of that as we went along. So we got these people upskilled and started to work on critical care and switched to a 7-day service. Pre-COVID we were a 5-day service, but it became apparent to us that we needed to go to a 7-day service. Had new patients being admitted every day, patients with complex needs, and it was really important to us that we could have regular assessments and regular reviews for these patients. Nutrition in COVID-19 patients, as it is with all ITU and all hospital inpatients, is extremely important. These patients come in very unwell, often with pre-existing comorbidities, and it's really important that they get a bespoke, patient-centred assessment initially, and then reviews ongoing to manage any complications. These patients have a severe inflammatory process, which just means they lose weight very quickly, decreases their function, and it impacts upon their long-term rehab. So it's really important for us that we be able to see these patients and be able to advise on their nutritional management as early as possible. So we initially started that by doing phone reviews. This was to secure PPE supply, and because initially on the unit it was mainly doctors and nurses that were going on, and so we tried our best to manage this via the phone. This had its own set of challenges. It certainly placed a burden on nurses having to come to and from the phone to give us the information, and we couldn't always get the sufficient information we need to feel comfortable and confident that we were giving a thorough assessment that was befitting of these patients. So we tried our best to manage that way, and we've certainly given advice over the phone, but as soon as possible, as soon as PPE was secured and we were allowed to do so, we started to go onto the unit and do face-to-face assessments. This is far more familiar to us. This is what we've done previously, obviously going on ward rounds and seeing patients face-to-face, being able to get all the necessary information to give a thorough assessment and being able to give a bespoke plan to meet these patients' needs. From a nutritional point of view, these patients had their own set of challenges. There was a lot of GI intolerances necessitating management of their feeds. We do that, we have different feeds and different strategies to use to manage any GI disturbances they have. A lot of these patients were fluid overloaded, so they had fluid restrictions. That makes it harder to meet their calorie and protein requirements because you have less fluid volume to work with. So it's important for us to be able to see these patients and to advise on how to best meet their requirements whilst working within that fluid restriction. A lot of these placements on renal replacement therapy. That has its own set of nutritional demands. There's a lot of nutritional losses due to the process of the renal replacement, so it's important for us to be able to see those and advise on that. The patients being proned, in proning, often it's quite common to have GI issues due to the position of the patient, so we had to go on and advise on how to best meet their requirements by decreasing the rate and making sure that they were being fed in a safe manner whilst proned. These patients had high sedation requirements. That has its own sort of set of challenges. You get a lot of the calories from things like propofol as a calorie content, so you have to manage that in a larger picture of their nutrition to make sure you're not only providing enough calories, but you're not overfeeding and having the negative consequences of that. We also had to consider the long-term sort of picture for these patients, so we had to make sure that we were meeting their protein requirements and calorie requirements as early as possible and as adequate as possible, and Rebecca will go into some of the specifics on that later on, to make sure that long term down the line when they did recover that they would then be in the best picture for their rehab. Nutrition is tremendously important for the rehabilitation process, so it's very important for us to get on there and give bespoke one-to-one specific management for these patients. Some of the other challenges that we faced, things like documentation. Initially we were trying to use Hospify, but that had its own set of challenges as inherent with using any sort of new technology. Eventually we did move to scanning out documentation, which made things easier, but it still did sort of hinder that natural process of documentation that we were used to, and it did add a little bit of an extra burden onto us, having to work within the PPE and these challenges that we had with adequate documentation. Luckily we overcame that with the help of technology, and that was ultimately resolved. Other challenges we faced was our enteral nutrition supply. As I said, nutrition for these patients is hugely important, and most of these patients were tube fed, so making sure they had a supply of their enteral nutrition was kind of difficult. We had to make sure each area, which was often separate and you couldn't access through each area, to make sure that they always had enteral nutrition on hand to feed these patients. Communication with the team was sometimes a bit more difficult. We were used to going on ward rounds and being able to communicate very directly with doctors, but due to the nature of this pandemic, ward rounds were happening at different times and we weren't always able to attend the ward rounds, so communication was a little bit difficult. But I'm going to hand you over to my colleague Rebeca now, who's going to tell you about some of our outcomes and how we overcame these challenges.
Okay, thank you, Steve. So as Steve mentioned, I'm Rebeca Prichard, one of the other critical care dietitians, and I'm going to talk to you about the data collection that we did during the first wave of COVID-19 on the intensive care unit, look at the main dietetic outcomes of this, and also think about future considerations in anticipation that there may be a second wave of COVID-19. So as Steve previously mentioned, we very quickly transitioned from doing remote reviews to face-to-face reviews. This put us in a really perfect position to be able to collect data on all our patients as we saw them. So this meant that Steve and myself were able to retrospectively then analyse this data in order to look at dietetic outcomes. We felt it was really important to collect data, one because our service provision had greatly changed, and therefore we wanted to look at the impacts on that in terms of our dietetic outcomes, and then be able to make direct comparisons to our audits that we've done prior to COVID. As well as the fact there is a lack of evidence out there in terms of how to nutritionally manage COVID-19 patients, and therefore we felt that by auditing what we did during this period of time, it meant that we could add to the evidence in terms of how we should manage these patients. So we collected data from the date that our first COVID-19 patient arrived on intensive care unit and needed our input. So this was on the 22nd of March this year. And then we retrospectively collected data up until the 4th of June. This enabled us to have data on 66 patients during this time period. We collected a vast amount of demographics on these patients in order for us to see how the UHW ITU patients compared to other ITUs by looking at the ICNARC data. But most pertinent to dietetics was looking at their pre-existing malnutrition and their BMI. So we found in terms of pre-existing malnutrition, when we each individually, so any dietitian who's gone to unit, assessed each individual patient by looking at their pre-existing weight, their any unintentional weight loss, any comorbidities, etc., which would then lead us to believe they were already malnourished. We then found that only 9% of our patients had pre-existing malnutrition, and we found that about 53% had a BMI of over 30. As Steve's already mentioned, the novel disease of COVID-19 brought a number of factors which had great nutritional complications and implications to our patients. So we found that 42% of our patients required filtration, 36% required being placed in the prone position, and 88% of our patients required propofol, with interestingly, on average, 10 days of propofol at more than 10 mils an hour being required, so obviously having a significant contribution to non-nutritional calories. When looking at our 66 patients, we found that 62 of those patients required enteral nutrition during their ICU stay, so this is about 94%. And interestingly, when comparing ourselves to European guidelines, so for example the European Society of Parenteral and Enteral Nutrition, who recommend the gold standard is to initiate feeding within 48 hours, we found that 92% of those who required enteral nutrition started feeding within 48 hours. This is really positive in the fact that, like Steve mentioned, initially dietitians weren't able to be on the unit, which obviously we quickly changed to make sure we were there, but also because they're very complex patients. So for us to be able to maintain that standard at 92% was very positive and really shows how the whole of ITU really worked together in order to maintain standards of care. Another thing that we looked at, which we thought was a really important outcome, was looking at feed delivery. So we had previously looked at feed delivery on a pre-COVID audit, and this gave us a direct comparison therefore to see how our change in dietetic services, but also the change in patient presentation with COVID-19 impacted on our feed delivery. So we found that 82.4% feed delivery was achieved in these patients on average. This is very, very similar to our pre-COVID audit, which found that 85%. We felt this was a really important finding because actually the patients that we had admitted during our COVID-19 period of time, 36%, like I've previously mentioned, required being placed in the prone position, whereas actually in our pre-COVID audits we'd had no patients requiring proning. And also 35% of patients required prokinetics due to GI intolerances, whereas in our pre-COVID audit, only 29%. So both these factors, so being placed in the prone position and being on prokinetics due to GI intolerance, mean that we're unable to use catch-up feeding, which is usually the way that we can ensure adequate feed delivery and optimise feed delivery. So it's even more impressive that despite the complications that these COVID-19 patients had, that we were still able to maintain a really good percentage feed delivery. And obviously this also backs up the fact, like Steve was mentioning, it wasn't just myself and Steve working on the unit, we had lots of dietitians who were upskilled to be able to work on the unit. So this shows that actually their training along with ourselves was thorough in order to ensure that they were on the unit being able to manage any GI complications or any other complications and promote the optimisation of nutrition delivery. We also found when we're thinking about how we nutritionally manage patients with COVID-19, we found that 60% of our patients on their initial assessment required a fluid-restricted feed, which obviously has great nutritional implications. So obviously if you're using a lower rate of feed, it's trying to balance fluid restriction but also adequate nutrition. So often these feeds are lower in protein and lower in micronutrients, so it can be more difficult to feed adequately. And the main reasons for using these feeds were the fact that they had stricter fluid balance targets, so trying to dry them out due to overloading, and also being in the prone position. By using a lower rate of feed, you lower the risk of aspiration, which would obviously exacerbate their current issues. So this we found was the main feed that we were aiming to use, the lower volume feeds, and therefore we did use more protein supplements in this patient group in order to increase the amount of protein that we could deliver. So surprisingly, our parenteral nutrition use was a lot lower than anticipated, so only 2 out of our 66 patients required parenteral nutrition. Which we were quite surprised at due to the fact that emerging evidence was suggesting patients with COVID-19 had high GI intolerance and therefore required parenteral nutrition more often. We felt this is partly actually due to the fact we had a 7-day service, which meant that we could assess patients very regularly, and therefore if they're having issues we would be able to tackle those more quickly than if we had been a 5-day service. But also the fact we have robust bowel and prokinetic protocols which the ICU team continue to follow throughout the COVID-19 pandemic in order to ensure that we could try and manage these GI intolerance issues without requiring parenteral nutrition, and therefore go on to optimise enteral nutrition. Unlike many other centres, we focus our time on upskilling dietitians and being on the unit, seeing patients, giving bespoke feeding regimes. We decided to do this rather than producing a COVID-19 algorithm, because our experience of doing remote reviews found that actually this added a large amount of burden onto the nursing staff, and therefore we felt that by giving nurses or doctors an algorithm, this put a large amount of burden on them and meant that we weren't there to give our nutritional expertise when discussing patients and deciding how to manage their feeding. Therefore, we felt that one size doesn't fit all, and therefore we needed to be able to assess patients individually and to give the most appropriate feeding regime to each patient. And obviously this was shown in the fact that we had 110 changes throughout our audit or data collection of feeds. So this was changing feeds for patients as they went through their journey. Obviously, if there'd been a protocol or an algorithm that was used, they'd stay on the same thing throughout their journey, which meant they may not be getting the optimal amount of nutrition depending on where they are in that intensive care journey. We also found that along with all ICU survivors, there was a large amount of weakness, fatigued, and significant weight loss and muscle loss, and therefore we felt that nutrition was really important, not only in the ITU time but also when they are going on to the wards. So we felt it was really important to make sure that any patients we didn't think would be able to eat and drink adequately could then continue their NG feeding on the ward. So we made sure we discussed each patient when they're ready for the ward with the MDT to ensure that if there was a risk of dislodgement of the tube, a nasal retaining device was inserted, and that tubes weren't pulled out early. So they had those tubes in their noses for the time being until we knew they were eating enough, because obviously as Steve has previously mentioned, nutrition underpins that rehabilitation process. So kind of in conclusion, obviously like all members of healthcare and actually the population during this time, it's been very challenging, but we felt as a team of nurses, doctors and AHPs that we worked together to ensure that patients' care was put first and they were given the optimal care possible. We have written up a report looking at our dietetic outcomes and submitted it to the British Dietetic Association, and are now in the process of considering how we would manage a second wave. Obviously, from all the experience we've had of the first wave, this puts us in a much better position than where we were previously.